You around as the day goes on. Before we start, I want to remind everyone to please come to lunch. Start at around 12, Cindy, correct? So we can all get together at that time. Looking in the back of the room, I want to welcome Dr. Peter Bone, longtime colleague, neurosurgeon, faculty member, mentor to many, and glad you're here this morning, Peter. Love to see you back again. I want to congratulate the residents and faculty on what I've heard in the hallways and back doors about the EPIC transfer. I know it's been an epic pain, but it sure sounds like you guys have taken the lead in trying to make this work for the benefit of the institution, and I appreciate that, and I think everyone else here does as well. So we're really happy that it's going as well as it is, even though it's still painful and probably will be for several more weeks or months to come. On our grand rounds on interview days, we usually showcase a couple of our residents showing the case. That we do this 2 or 3 times a month, 4 grand rounds, and then have visiting speakers or local faculty at other times. So we're going to start off this morning with Stephen Greer. Steve is a native Chattanoogan who went to UT to medical school, UT being the University of Tennessee, and then has come here for his residency. And he's going to present a paper that he recently presented at one of the national meetings. Okay, thank you.
Thank you, Dr. Burns. Thank you, everyone. I'm Steve Greer. I'm a 5th-year resident. I'd like to welcome everyone to Chattanooga. Made a few little slides for the applicants. So, I think everyone in this room really likes this town. Beautiful city, a lot to do. These are some stock photos off the internet of it. This is the Bluffview Art District. This is Miller Plaza, rather. A lot of concerts down there. Just picture the river. This is Riverbend Festival, so a big concert on the riverfront. And everyone with a boat comes for fireworks tonight. A lot of outdoors things to do. If you like mountain biking, ton of mountain biking, climbing, all kinds of water sports. Mountains and rivers everywhere. And we as residents sometimes get to get out and do it. And also, I have a lot more pictures, but I struggled with transferring technology, so there's one. But we also do some operating. This was a month or so ago. That's a sigmoid colon that was a little bit big, had been volvulized a little bit, and we took it out. So anyway, the paper I want to present I did with Dr. Hedrick, who's one of our thoracic faculty members. This was presented at the Southern Thoracic Surgical Association about 2 weeks ago down in San Antonio. There's a podium. I think we were the fourth one to go. It was a lot of fun, pretty big honor to help Dr. Hedrick present this paper. Thought it had some really interesting data. It generated a lot of conversation. Anyway, so this is a little more formal than my talks sometimes are, but we'll do it like we did it down there. So anyway, so the title of this paper is Safety of Next Day Discharge After Lobectomy, Have We Broken the Speed Limit? I have no disclosures. We as humans have always strived to push boundaries. Seeing things that stand in our way and pushing through the things that hinder us have allowed us to have the success as a species that we have enjoyed. Whether it is to conquer the highest peaks, push the physical and mental limits of our bodies, or break frontiers of speed and sound. While these examples exhibit our highest ambitions, sometimes the barriers we wish to break are less ambitious, but no less important to the individual. And sometimes, in spite of our best efforts, barriers are not meant to be broken. In the field of medicine, pushing through barriers takes a different form. While all the previous examples required great sacrifice and risk on the part of the individual, in medicine we sacrifice not only our own safety but that of our patients as well. As we try to push the boundaries of treatment, we must maintain constant vigilance in guarding the safety of our patients to ensure that we don't go too far, too fast. In the last decade, there has been a revolution in thoracic surgery. In addition to improved surgical techniques, fast tracking, enhanced recovery, and outpatient chest tube management have all helped to reduce the postoperative length of stay following lobectomy. Currently, the STS Thoracic Surgery Database reports the mean hospital length of stay following lobectomy to be 5.3 days. Some programs are reporting a much lower length of stay, including next day discharge, though there is currently no data in the literature to support the safety of this practice. We set out to devise a system. The standardized approach to air leak reduction is a way to reduce prolonged air leaks in our pulmonary resection patients. STAR utilizes 3 independently identified factors shown in the literature to decrease prolonged air leaks, which include fistulous dissection, staple line buttressing, and a protocol-driven management of chest tubes. The end result has been a steady decrease in hospital length of stay, such that many of our patients are being discharged within 24 hours of their admission. In this study, we analyzed our STAR database comparing outcomes of patients who underwent a lobectomy and were discharged on post-op day 1 to the outcomes of lobectomy patients with longer admissions. Specifically, we were interested in the impact next-day discharges might have on morbidity, mortality, and readmission rates. In this study, we identified 390 patients who underwent lobectomy and met study criteria. For consistency purposes, thoracoscopy was our preferred approach to minimally invasive surgery. Any robotic lobectomies or patients who had a sublobar or more than an anatomic lobectomy were excluded. In the study, we had 2 arms, with 150 patients discharged on post-op day 1 and 240 patients in the comparison group who were discharged later than post-op day 1. The mean length of stay in this comparison arm was 3.9 days. The baseline characteristics were mostly similar between our 2 groups. No significant differences existed between the 2 regarding sex, age, race, BMI, or the prevalence of COPD, coronary artery disease, and diabetes. Distinguishing characteristics in the post-op day 1 group included more patients who had never used tobacco, increased utilization of minimally invasive techniques, right middle lobectomies, and a lower incidence of prolonged air leaks. Patients discharged on post-op day 1 were less likely to be discharged with a chest tube versus the comparison group. FEV1 and DLCO data were also favorable in the post-op day 1 group. There was no significant difference in 30-day readmission, morbidity, or mortality between our 2 groups. There were 14 total 30-day readmissions in our 2 combined groups. 3 patients in post-op day 1 group were readmitted for GI bleed, pain, and COPD exacerbation, while 11 patients in the comparison arm were readmitted for pain, COPD exacerbation, DVT, Coumadin-related complications, pulmonary embolus, superficial wound infections, and altered mental status. There was no statistic difference between these 2 groups, and the combined readmission rate was 3.6%. The overall mortality rate was 0.8%. There was no statistic difference between these 2 groups. In the post-op day 1 group, 2 deaths were due to myocardial infarction and massive GI bleed, both of which occurred more than a week after discharge. The single death in the greater than post-op day 1 group was due to pneumonia and ARDS. It is unlikely that extending the initial hospital stay would have affected these outcomes. As we started this study, we were very cautious about sending patients home on post-op day 1. As our data began to grow, we were able to become more comfortable with next-day discharges, as were our patients. In the first 3 years of the study, 23% of our patients were sent home on post-op day 1. In the last 3 years of the study, this number had risen to 63%, reaching a peak of 76% in the last year of our study. In 2014, we became more comfortable with the data supporting post-op day 1 discharges, and as we escalated early discharges, we saw no decline in outcomes. In conclusion, our data suggests optimizing preoperative lung function, focusing on surgical technique that prevents air leaks, and utilizing a minimally invasive approach will increase the odds of a patient being discharged on post-op day 1. A continued focus on lobectomy length of stay reduction could have the capacity in appropriate patients who undergo lobectomy, post-op day 1 discharge does not increase morbidity, mortality, or 30-day readmission. A continued focus on lobectomy length of stay reduction could have the capacity to increase patient satisfaction and lead to reduction in healthcare costs and more efficient delivery of healthcare. In the case of next day discharges, we have not broken the speed limit. Thank you.
Well done, Dr. Greer. Questions, comments? Yes, Dr. Smith.
Very nice, Steve. But it brings up the question of, and I didn't see this, did you have a thoracic surgery scoring system to compare the initial illness of the patient? I mean, these patients smoke, they have some comorbidities, but I didn't see a scoring system like sometimes we use in trauma to better delineate these patients. And the ones who went home greater than 1 day seemed to come back with more complications. So I'm guessing that the patients who stayed in the hospital were sicker to start with than the ones who went home post-op day 1.
Yes, sir. So there were some differences. You know, CT surgery has pretty robust reporting systems. It's more on the cardiac side than thoracic side. But going back, I guess, to 100 clicks from now, you know, looking at the comorbidities, the greater than post-op day 1 patients were a little bit sicker. Some of the things that were, you know, difference, that did show statistic difference. You know, things like, you know, let's go over here actually. Well, where is it? Anyway, they I guess passing that, they were a little bit sicker, but you know, looking at the readmissions, the other thing to keep in mind, the greater than post-op day 1 group was a bigger group, so there wasn't a statistic difference between 30-day readmissions, but it's certainly something to think about. And at the end of the day, you know, we try to do protocols, but you know, you have to look at your patient and at some point decide if they're ready to go or not. And so this is certainly not for every patient. We weren't trying to say that it was, but that basically describe that this is an option that can be done safely.
But it looks to me like, I'm with Dr. Smith, though, with the data that you have there, you could put together a rough score here of risk stratification pre-op and then immediately post-op by adding what kind of surgery you did and your approach, right?
Yes, sir. Yeah, and I guess in regards to that question, there's not a scoring system like the injury severity score or anything like that.
But makes you wonder if you looked at your data some more.
That's a really good point.
If you couldn't with enough patients, you could maybe come up with at least a rough score. It wouldn't be an absolute indication to proceed or not with rapid discharge, but you had a lot of information there, like the smoking issue, the air leak issue. That you wouldn't know that, I guess, until post-op.
Yes, sir. And there's actually quite a bit more. This is kind of the pertinent data. We collected quite a bit more than this. But, at risk.
Age did not have any effect, you said?
No, sir.
Okay. All right. Other question? Yes.
Yeah, I enjoyed your paper, Stephen. You highlighted technique in reduction of air leak, but I didn't quite get how many patients actually went home with their chest tube, and if you do go home with a chest tube, does it require special home health nursing to follow these patients, or is there some protocol that is in place for that?
So the way that we do it, basically the home with chest tube would be 10 patients out of the 150 went home with a chest tube in the post-op day 1 group, and 51 out of 240 went home in the greater than post-op day 1 group. These are mostly due to air leaks, and the way this paper initiated was basically an air leak reduction. As far as how these patients are managed, basically they're followed every 72 hours. They're sent home with instructions and a Atrium Mini on water seal. And they have to prove that they can tolerate water seal, that they're not having any respiratory distress or not having any worsening pneumothorax. And they go home, and basically they'll come in 72 hours to the office. They're reevaluated. If they still have a persistent air leak, they go home again 72 hours back into the office. And we've not had to readmit anybody for that. Eventually we've been able to get them all to stop.
But in addition to checking for air leak, do you do chest x-rays at that point looking for asymptomatic pneumo? You don't worry about that? Okay.
So 10 patients out of the 150 went home with a chest tube?
Yes, sir.
That's pretty amazing that the surgery's that good. They don't have
Yeah, so and that, going back, I guess, there's been a lot of kind of refinement in technique, and Dr. Drahush presented this paper a few years ago. And like I said, this was, and actually Dr. Royer was also involved with this data set. She did the first presentation looking at some of this data. You know, staying out of the fissures has been shown in multiple papers to reduce your air leaks, and then buttressing the staple line using it's a kind of a membranous staple line buttress, and then using protocol-driven chest tube management, meaning having an idea, kind of the things we talked about. You know, and the other big part of this is really a lot of this work's done in the office before surgery. You know, there's a lot of counseling involved. These patients have to know what to expect. You know, if you do the surgery, come in the next day, say, all right, I'm sending you home with this chest tube, they're not going to respond to that very well. But, you know, if they know, you know, what the plan is ahead of time, and you know, and it takes some counseling. It usually takes 15, 20 minutes for these patients to go over everything prior to surgery. And most of them are, you know, ready to go home. They're, you know, there's no data for this. Anecdotally, they're very happy to sleep in their own bed, and they do pretty well.
Yeah, I want to editorialize on that just a little bit. I think we've all found that to be the case. I know in discussing same-day mastectomy with patients, if you don't prepare them for that preoperatively, it's really hard to convince the patient and the family on the day of the operation that you know that you can go home from having your breast removed. And I think the same thing is, we found that same thing with our fast tracking of the colon work. Is that not true? So I think that work in the office, where it gets pretty hectic and time sensitive, really is important for you to be able to do, either by you or by someone in the office, to make that clear to the patient. Dr. Giles?
Steve, just a quick question about your procedure. So 71% had, in the post-op day one, greater than post-op day one, had something other than a VATS with those thoracotomies?
Yes.
And if so, why would you include thoracotomies when you're comparing 100% to thoracoscopic? And the second question is, why do you feel that robotics is different? Why do you not include robotics? Would you not just consider that an extension of minimally invasive laparoscopic surgery?
You can. The reason thoracotomies were included, you know, granted, you're much less likely. It's a bigger operation. There's more pain. We included those because, you know, I think there have been one or two that were sent home because they were doing really well. Their pain was controlled. And really, the focus of this, especially initially, was looking at, you know, your air leaks and things like that. As far as robotics goes, it really just, the sample size was pretty small and trying to keep things apples to apples. The approach of how you do a robotic lobectomy is different than how you do a thoracoscopic lobectomy, as far as, you know, taking, you know, the pulmonary artery and the pulmonary vein before the, you know, before the bronchus. And Dr. Hedrick, I think he's done about 8 to 10, decided he liked thoracoscopic better. And so he didn't really do enough. I think there's no reason that robotic, you know, literature, if you studied robotics, would not be similar. There's just very few to choose from, and it kind of confused the issue as far as, you know, changing the protocol that was in place, and so we just excluded those.
Dr. Moore?
I just have two comments and one question. It's a perfect example of the old adage that the wards in the clinics and the laboratories are the highest order, and what a very busy teaching faculty member can do that can advance science along with the resident, bringing along education here at the facility. Your GI bleed guy, was this same mortality, the guy that got admitted for GI bleed, was he the mortality GI bleed, and do you know any idea why he would have such a massive GI bleed so early?
That patient, as I recall, was readmitted, and I think it was around 2 weeks post-operatively, and it was actually, I think, died pretty quickly. I think came in an extremis.
You don't have any
so
good idea whether that could have been predicted earlier or anything?
I
He
can't.
wasn't cirrhotic, he didn't have varices, you know, something kills a guy with a GI bleed.
I'm not sure, and the GI bleed was somewhat presumed,
Okay.
just because they came in extremis and died in the emergency department.
Great paper, though.
Other questions or comments? I think this is a beautiful example, as Dr. Moore says, of what a faculty member with residents can do. Because if you go back, as you already pointed out, 2 of our other residents for our visitors have done papers along the way in this, the discharge with chest tubes in and so forth.
Yes, sir. It's really neat. Dr. Hedrick's system he's got in place, is really neat to see how he's got everything set up. And, he started this primarily just to track his own results. Is how this data set started. He started looking at it thinking, why can't I send people home early? He's told by many people, including his partners, you're going to kill people doing this. And he said, I don't see any data to say I can't. I'm looking at this patient sitting in the hospital for 4 days, not doing anything. But he said, I don't know, this may be dangerous. So, starting the data set, kind of figuring out what your technique's going to be, and then following, tracking your own results, making sure you're doing the right thing for your patients. And, on the way, accumulating a lot of data that you can go out and then present and support and, potentially, this could potentially have pretty big impacts, in the world of thoracoscopic surgery. 5.3 days is the mean, which means some people are keeping people 7-8 days. They're just sitting in hospitals, taking out resources. Also, the patients aren't as happy, So, like I said, this was one of the more talked about papers. It was a pretty healthy discussion after presentation because,
I would imagine it would have.
Yeah.
But sure, it is important. We doctors take a defensive position and sometimes an offensive position against our critics about the cost of health care. But if we're not sensitive to the cost, then we're going to get left in the dust. And this is an example of a way to help improve both patient care and cost. So really another good step in the right direction. Thank you, Steve. Good job. Our next presentation is going to be by Richie Tanner. Richie is a University of Alabama graduate, second-year resident. He's going to do a case report. Is that right?
Yes, sir.
Present a case.
Good morning, everybody. Also want to welcome the applicants. Chattanooga is a wonderful place. We're not here in the hospital. There are lots of great things that Steve pointed out in his wonderful photographs of things to do. I'm going to talk about this case of intussusception in this patient. I'd like to thank Dr. Darren Hunt and Brent Soder for helping me with this presentation. I have no disclosures. So in this talk, I'm going to present my patient and talk a little bit about intussusception, and then discuss inflammatory fibroid polyps, do a literature review, and then Dr. Burns likes, when we present, to keep in mind cost of medicine, so I have a tidbit about that. So our patient was a 50-year-old female who presented with a 3-day history of right-sided abdominal pain. She said that for the first 2 days it was just an intermittent kind of colicky pain, but then on the day of presentation it acutely worsened and became constant. She also reported over that 3 days some bloating, nausea, vomiting, anorexia, and some intermittent bright red blood per rectum. She denied fevers, chills, or sweats. Her past medical history was significant for uterine prolapse. Otherwise, she was a healthy individual. She did have a laparoscopic hysterectomy. No medications, no drug allergies. Her family history consists of lymphoma in her mother and atrial fibrillation in her father. She denied tobacco, alcohol, or drug use. She was afebrile on presentation. Her vital signs were within normal limits. Physical exam, she was in no acute distress. Her abdomen was soft, was mildly distended, and there was some tenderness palpation in the right lower quadrant, but no rebound tenderness, no evidence of peritonitis. She did have a leukocytosis, white count of 14.7, and her lactate was slightly elevated at 1.68. Otherwise, her other labs within normal limits. We did obtain a CT scan of abdomen and pelvis. And as you can see, she's got some fluid around her liver, around the spleen. I want you to pay special attention down here, the ascending colon. Right here specifically, you can see this thickened cecum and this, what we call a target sign, which appears to be small bowel inside the large bowel. And we can follow that down and can actually see here where the terminal ileum is actually invaginated into the cecum, and you can see here the mesentery of the terminal ileum as well. I have a coronal image as well, and again, pay attention to this right lower quadrant. Here you can see again the cecum, and then the ileum invaginated into the cecum, and then you can see mesentery there. So the radiology repeated was intussusception of the terminal ileum into the cecum, and then there were also multiple dilated loops of small bowel with some air fluid levels that was consistent with a partial small bowel obstruction. So intussusception, it's when you have an area of proximal bowel that invaginates or telescopes into distal bowel. So here on this picture it shows an ileocolic intussusception, and you can see the ileum here, that's invaginated into the cecum. And here's a representative photograph. Again, you can see the terminal ileum, the cecum, the appendix, and the terminal ileum looks like it's telescoped into the cecum. So intussusception, you look at it in two ways. You look at it, there's kids versus adults. So 95% of intussusception occurs in children, and in fact, it's the most common cause of bowel obstruction in children. The vast majority of cases of intussusception in children, or 75%, is idiopathic, and it's thought to be a viral cause. The Peyer's patches is the lymphoid tissue that's in the small bowel, and when there's viral infections, that lymphoid tissue can grow and can cause a possible lead point for the intussusception. The other 25% in children, percent of intussusception is due to a defined lead point, and the Meckel's diverticulum is the most common cause. So with kids, the general treatment principle for children with intussusception is non-surgical reduction, we'll call it air enemas, and those are for the patients that are stable. If you do have a child, though, that's unstable, if they're toxic, have peritonitis, or they failed multiple non-surgical reductions, then that's an indication for surgery. So in adults, intussusception is much more rare. In fact, it's about 5% of all intussusceptions. It was interesting to me, though, that up to 5% of bowel obstructions in adults are caused by intussusceptions. That seemed kind of high, but that's what a couple of the articles that I read said. But with adults, up to 80% of intussusceptions have a defined lead point, and over half of those are malignant. So the general treatment principles for adults with intussusception, if it's a symptomatic intussusception, you're going to typically take the patient to surgery. You can do laparoscopy possibly to look for a lead point. So the plan for our patient was to go to surgery. At first she was taken to the operating room, and there was a failed attempt to reduce the intussusception by diagnostic laparoscopy. At that point, it was decided to convert to a hand-assisted laparoscopy, and so then what happened, the hand port was placed in the midline, and a hand was placed into the abdomen and exteriorized the affected small bowel, and then the intussusception was reduced by hand. There was an intraluminal mass palpated at the intussusception site, and that mass was exteriorized. There was a longitudinal enterotomy made over the area of the mass, and what was found was an 8-centimeter long pedunculated mass that had a 7-millimeter base. At that point, a small bowel resection was performed with a hand sewn side-to-side anastomosis. Here's a picture from the operating room. So this here is the serosa of the small bowel, and you can see this purple ink. That's where the longitudinal enterotomy was made and flipped inside out, if you will. And this here is the intraluminal mass. So the pathology report showed this as a polypoid lesion that arose from the submucosa. It has numerous variably sized vessels and mixed inflammatory infiltrates, including eosinophils and some other cells. And then there are also some areas of CD34 positive spindle cells, which we'll talk about in a minute. No evidence of dysplasia or malignancy, and the diagnosis of inflammatory fibroid polyp was made. So here's some histology slides. I'll go through these very quickly. So on this side up here is the bowel lumen. The villi would be up here, but they're just not in the picture. This these glands here are mucus glands right at the base of the villi in the mucosa, and this area here is the submucosa. And the submucosa typically is kind of an off-white to gray color, and it's pretty bland looking, and it's a lot of connective tissue. But here you can see all of this infiltrative, these are eosinophils and all these blood vessels that shouldn't be there. So all of this area here is tumor. And then here's a magnified picture, and you can see these eosinophils and this onion skin or whorled appearance around the vessels. And then this is just a little bit more magnified picture with the inflammatory cells and the onion skin appearance. And then here's a picture of the CD34 staining. Again, we'll talk about it in a minute. And the brown or the stained cells. So inflammatory fibroid polyps, they're idiopathic, localized, non-recurring neoplasms. They're benign. They originate in the submucosa of the GI tract. So with that being said, they're intraluminal masses. These polyps are mostly found in the gastric antrum, up to 75%, but up to 20% are found in the small bowel, up to 4 to 7% in the colon, and then a much smaller percent are each found in other parts of the GI tract. The incidence of, found this study that looked at 120,000 patients nationwide that had gastric polyps, and up to 3% of their gastric polyps were these inflammatory fibroid polyps. As far as incidence in the small bowel, every paper that I read said they were rare, so I could not find a published incidence. So these inflammatory fibroid polyps are also known as Vanek's tumors, and that's named after Dr. Joseph Vanek, who's a Czechoslovakian pathologist. In 1949, he published a case report of 6 patients in the American Journal of Pathology that had these peculiar submucosal lesions that were found in their stomach. And some of the things they had in common in their histology, they all had a basic connective tissue composed of fibroblasts and loose connective tissue, infiltration with eosinophils, and then the blood vessels that I talked about earlier. And at that time, in 1949, Dr. Vanek considered this to be a reactive lesion, possibly due to an allergic etiology. So fast forward to 2008, there was a paper that came out in the Journal of Pathology that found that there's actually, these inflammatory fibroid polyps are actually neoplastic. They have mutations in the platelet-derived growth factor receptor alpha gene. And in fact, it's found that inflammatory fibroid polyps have these mutations in up to 70% of them. It was also interesting to see that there was a genotype-phenotype correlation. These polyps that are found in the small bowel typically had mutations in this mutation on exon 12, whereas the gastric polyps had mutations on exon 18. So the presentation for these fibroid polyps these things are typically asymptomatic, and they're incidentally found on endoscopy. When they are symptomatic, it's due to mass effect from their size. So the polyps that are large enough to be symptomatic in the stomach will typically cause abdominal pain, and the ones in the small bowel will typically cause intussusception or obstruction. Some other symptoms: nausea, vomiting, diarrhea, bloody stools, alterations in bowel habits. And these usually present in the 5th to 7th decades of life, but I did find the range of 5 months to over 90 years of age. So on gross pathology, this here is just a representative photograph. There can either be pedunculated or sessile, and it's been found to be from anywhere from 2 millimeters to 20 centimeters in diameter. And again, they project into the bowel. And then the mucosa will often be ulcerated and pale appearing. And on microscopic appearance, they're composed of a mononuclear spindle-shaped cells that have a whorled or onion-shaped appearance, and then they have the inflammatory infiltration. You can, again, see these down here. So it's important to distinguish tumors, generally speaking, between benign versus malignant tumors. And, as I said, these inflammatory fibroid polyps are benign, but there are some lesions that look very similar and mimic inflammatory fibroid polyps that are malignant. And one that came up in several articles I read were these GISTs. So gastrointestinal stromal tumors, or GIST, just to review, these are malignant mesenchymal neoplasms that arise from the interstitial cells of Cajal, and they're commonly found in the stomach, and they commonly present as polyps. They're also found in the small bowel and cause intussusception. So that sounds very similar to the presentation we had of this patient with this benign process. So histologically, these can be differentiated. Both these fibroid polyps and GIST stain positive for CD34 and vimentin, but GIST are positive for CD117, and these inflammatory fibroid polyps are negative for CD117. So the treatment for inflammatory fibroid polyps is surgery. They're benign tumors. There's no metastatic potential, and there's minimal chance for recurrence. In several of the papers I read, it was anecdotally mentioned that there is a chance of recurrence, but there was no data, no case reports or anything of any recurrence that I found. So this is a nice paper that I found. It was a literature review of inflammatory fibroid polyps that cause intussusception, and it's a case report as well. And in their case, this 38-year-old female who had abdominal pain was found to have an inflammatory fibroid polyp that caused ileal intussusception, and she had a segmental resection and did well postoperatively. So the literature review, they looked at the years 1976 through 2011, and they found 85 total cases of intussusception that were caused by these polyps. The age range in this group was 4 to 81. The average was 49, and it was pretty equal distribution between men and women. The location of the polyps in these patients, mostly they were in the ileum, as was our patient. They also were found in the jejunum, the colon, and in the ileal-jejunal junction. All had surgical resections, and then the average tumor size was 4.2 centimeters. Back to our patient. On the 25th of August was when she presented and had surgery. She had an uncomplicated postoperative course and was discharged home on post-op day 5 in good condition. She did follow up 2 weeks later and was doing well, tolerating a diet and having bowel function, had no issues. Cost of medicine, the gastrointestinal anastomosis or GI stapler costs about $264, and each additional staple load is $141. Questions do you have?
Questions, comments about a good presentation here? We have Dr. Carr here, pediatric surgeon. Dr. Carr, as he was making the presentation and discussing children, has anything changed about the incidence of successful non-surgical reduction of intussusceptions in radiology in the last 5-10 years, and about what percentage is that, would you guess?
It really hasn't changed in more than 20 years. Okay. The technique of doing it, the most popular technique now is a pneumatic enema as compared to a barium enema. Right. The success rate varies in the literature from 65 to 95%. Okay. Intussusception in children is much more common in the Orient than it is in the United States. And, it's not uncommon for hospitals in the Orient to reduce 10, maybe 20 intussusceptions a day. Okay. So there is a difference worldwide.
Do we have a reason? Is there a reason for that? Dietary, genetic, or what's the reason for that?
I've never seen an explanation for why that particular disorder varies around the world.
Right. Okay. And I know our trauma surgeon, Dr. Maxwell, may want to comment on this. We've mentioned several times during laparotomies, noting the small bowel intussuscepting, even though it's never been symptomatic that we know about.
That was what my question was going to be about, Dr. Tanner. Very nice job, such that I can't think of a question to ask you actually about your topic, but I will reach to a broader spectrum. And are you aware of the incidence of intussusception reported incidentally on CAT scans now? With the world of CAT scans, we've got 5-6 CAT scanners in this hospital going all day long, and we get a lot of consults about intussusception, and that may or may not be symptomatic. Did you uncover any data about what the incidence of an incidental intussusception on CAT scan is when you're
I did not
literature
see
review?
Any data on incidence, but anecdotally, I think that it's pretty high because I've actually, in my illustrious career, a year and a half now, have been a part of a couple incidental findings of intussusception. So I don't think that it's uncommon at all.
Yeah, Dr. Carr, you want to make a comment there?
Yes. We see small bowel intussusceptions on ultrasound and CT scans with such a frequency that it's not even, it's noted in the dictation, but it has no clinical significance. So a small bowel intussusception in a child is just almost like saying that the patient also has an appendix. Okay.
Yeah, Dr. Smith?
So I was going to piggyback on to what Dr. Maxwell said. I was actually going to try to say it first, but he beat me to it. But this is a perfect example how something in medicine, we're using data from 30 years ago prior to everybody getting a CT scan. If somebody came in with an intercepted piece of bowel, they usually lay at home with it for 2 or 3 days. They had pain. They finally show up. We diagnose with some other sort of radiographic study, and the interception by that time has proven itself that it will not reduce on its own. We see patients all the time now with a CT scan, interception. You check the patient an hour later when the report comes back and ER calls you, and they have no pain because it's reduced. We did one of these within the last week. At the time of laparoscopy, there was no interception, and the bowel didn't even look bad. I still think that if you find an intercepted piece of bowel, the way the old-fashioned thought was, you did not reduce it in surgery. You went ahead and did a segmental resection because there was some pathology causing this. At this point in time, I think if it reduces easily, you can. You're probably not going to get in any trouble, but I still think you need to take a look at the inside of the bowel in some form or fashion with capsule endoscopy or whatever method you deem necessary to make sure there isn't any internal pathology, even with the large flux of cases coming in.
Yeah, my follow-up comment to this conversation is that I think the small bowel is intussuscepting.
It's on.
All the time, and you may happen to catch that on a CT scan, and what are you obligated to do and follow up? If the patient did have symptoms that may be attributable to an intussusception, I think Dr. Smith's correct that you have to be suspicious that there could be some underlying pathology, and you probably do need some kind of additional follow-up if they present it with vague, crampy abdominal pain, and whether that's a small bowel follow-through or a CT interrography or something like a capsule. So I think if you do see a patient like that, you ought to offer them follow-up in the outpatient setting if they've come to the emergency room and consider some additional form of a CT scan if you think they had symptoms attributable to the intussusception. If you got the CAT scan because they were jaundiced and you saw intussusception, I don't think that's as pertinent. But if they had colicky abdominal pain, that's kind of puts it in a category that needs further workup.
In follow-up to this discussion, I would challenge you young surgeons-to-be and surgeons to look at a better way to identify this, because I believe there's a small number of patients out there that have intermittent chronic abdominal pain, even probably have partial small bowel obstruction. Sometimes you can demonstrate it. He has a resident, and he has a family member had family member that I won't mention in the spirit of HIPAA here, compliance here, but who I wondered many times if that was not the problem with that individual, but we never could document it on a CT scan or any other kinds of studies. And so I think that I would challenge you to try to find a better way, capsule swallowing, something, isotope study, because I believe there are some limited patients out there with chronic intermittent abdominal pain that probably are from intussusception. You want to make a follow-up comment?
Yeah, the conversation's gone all the way to anecdotes, so I'll go to that level too. We had a guy a couple of years back coming down from Ray County with chronic abdominal pain, and he would show up with intussusceptions, and this was back when we were starting to get our arms around the idea that we see intussusception a lot more than we thought we did with all these CAT scans. And this guy got several operations, came in on different nights with different faculty, and wound up getting scopes put in and looked for and couldn't ever find it sometimes, and he finally disappeared. Right. But I think he got about 3 operations for coming in with an intussusception that no one ever found a lead point.
Same thing in this circumstance, same thing with this. I would point out the residents have heard this several times. This patient had a hysterectomy, so it wouldn't have qualified here. But without that, this could have been a virgin abdomen bowel obstruction. And even without that CT scan, this patient would have needed an operation, right?
Yes, sir.
If you knew you had a small bowel obstruction and you saw the patient evaluate them. Virgin abdomen, small bowel obstruction, they have a surgically correctable problem. Not 100% of the time, but pretty close to that. And this would have been one of those. To have left this alone and sat on it and sucked on them with an NGT would have been a real big mistake. Other questions or comments about this case? Okay, we're going to break. You have time to stand, go to the facilities if you want to, and come back. We're going to talk to you here. Thank you, everyone. Have a good Thanksgiving. Good job, boy. Very nice, Richie.